Hello, everybody. My name is Mike Weiser with Community Link Consulting, and welcome to our webinar on navigating uncharted waters in the health center industry in 2025. And it's only been a couple of months of uncharted waters, but it feels like a lot of ice ahead of us here to break through, and we'll do our best to try to provide some tips and tricks to get through these strange waters. We'll do introductions in a little bit, but I'll just start off with some logistics. Of course, we're a webinar here with participant cameras and audio off. We do have the chat function and the question function for GoToWebinar, so please make liberal use of those. We'll try to watch the questions and be doing a combination of responding during the presentation and at the end during a longer Q&A. We've got a few polls during the session, so please be ready for that. We are recording this. It's probably going to age like cheap cheese or something like that. So don't worry, it won't be around very long. It's just going to be shared with folks who couldn't attend but registered. And slides are going to be emailed after the webinar. And last bit of keynote there, we're not attorneys. A lot of these federal changes are in the court system right now. We're not able to offer legal guidance, but of course we do have to talk about some of these changes even though they're going through the court system now. Our objectives today are to focus on the key changes for federal funding and oversight of FQHC so far. We're kind of assuming that most folks have been paying at least a bit of attention, so we'll kind of go quickly through those and focus more on the practical tips that will prepare your health center for change, with a lot of our focus on financial management, billing and revenue cycle management, grants and grant compliance, but we'll also do some overall grant strategy as well. And we hope to share what we're seeing our clients who are almost all health center organizations, what they're doing to address these challenges as well. So our agenda, we'll do some introductions, and then we'll go through the four of us with those different topics, and then we'll have a roundtable and time for Q&A at the end. We're scheduled for 75 minutes, and we'll try to wrap up on time. So since I'm talking, I'll start with me. I've been at Community Link for a couple of years, and before that, I had about over 10 years at a large community health center with a variety of experiences. And right now I focus on strategic planning as well as grants and development for the most part. Monique.
Sure. My name is Monique Dumond. I've been with Community Link Consulting since 2021. I am a CPA by trade. I've been a CPA for about 25 years now. I was also a CFO for a health center in Louisiana for about 12 years, and have seen pretty much everything in the FQHC world and physician practice management. I think Mark is next.
Hi, everyone. My name is Mark Sprague. I joined Community Link in 2020. I've been working about 10 years in the FQ world, including 5 years with the tribal FQHC in Northern California. My experience varies from financial to revenue cycle management and clinical operational management. So I have over 25 years of experience in healthcare, including 10 plus years in healthcare management. I'm originally from Maryland, but now I currently reside in Sacramento, California. Dina.
Hello. My name is Dina Green, and I am the Billing Department Director here at Community Link Consulting. I've been here since 2012 and have quite a bit of experience with FQHCs and all things billing and revenue. We have a great team here of 18 that help support our clients with billing services, and that is me.
Thank you. So why are we here today? Of course, we're all concerned about the actions by the new administration to affect health center funding as well as regulations. The federal budget expectations are looking quite challenging in terms of Medicaid funding especially. And in the health center program, net margins are already under extreme pressure. They were down to 1.6% on average in 2023, and one can imagine in 2024 that has probably dropped quite a bit. 2018 is not on the chart, that was about 0, so we're thinking that things are probably about that same way today, which means that around half of health centers have a negative margin. And if you have a negative margin for more than a couple of years, that creates a lot of additional pressure. So with all of that pressure, I'm going to launch a poll here around what your organization is doing in response to new federal directives and the budget outlook, and launch that poll. We have some Community Link consultants on the webinar as well, so you can think about your clients that you know best there and respond that way. All right, we have about 2/3 voting there. Okay, so about 3/4 of folks have voted, and this is one I should have tested before, but I'm going to close the poll and share the poll. So you can see about 60% not making changes, but you're here, so you're paying close attention, and about 1/4 making plans but not implementing them, and little less than 20% actively changing budgets and so forth. So thanks for sharing that. I'd be interested to see how this might change at the end of this, because we hopefully will get you into at least the second category of starting to make some plans. Okay, so starting with overall updates and high-level implications. It's my slides showing here. Okay. You know, Medicaid funding is a big concern. The House passed a budget that included $880 billion in cuts. Important to note that's over a 10-year period in time, and that's Medicaid's not noted in that budget, but it guides the committee overseeing Medicaid to make that much in the way of cuts. If all those cuts went to Medicaid, you'd be thinking about something like $88 billion per year out of the $606 billion in Medicaid spending. So that's a really big chunk, although GOP leaders are saying that would come from addressing fraud, waste, and abuse. The graph there on the right just showing the overall federal budget. So you have $6.1 trillion budget and $606 billion on Medicaid to give you a sense there. And also important to note, revenues are quite a bit less than our outlays as a country. So cuts or revenue enhancements do need to come from somewhere. If you've heard, I'm sure everyone has heard politicians talk about cutting fraud, waste, and abuse. They typically have very high expectations. The end result is I think I've never seen it to be as much as expected, regardless of political affiliations. So there's these other ideas to reduce Medicaid spending that we could expect having a significant chance of coming to fruition, at least in some scale, such as per capita cost shifts, where you cap the total amount of benefits that the federal government will pay on any particular year. You could see the feds reducing their match for the newly insured Medicaid folks who got their insurance through the Affordable Care Act expansion for those expansion states. 9 states will cut off their Affordable Care Act expansion if the feds decide not to continue that 90% matching rate. And then I know that at least 1 or 2 more would probably consider that or do that pretty quickly if that were to happen. The feds could also match or lower the matching floor. So that traditional Medicaid population, they might reduce the federal support there or add mandatory work requirements. And any of those situations would increase the state's responsibility if they wanted to keep the same number of folks on Medicaid. And then just in general, there are states that even if none of that comes to happen in the short term, are talking about pulling back on Medicaid expansion anyway. In terms of health center program funding, we saw a lot of challenges about a month ago with getting payment from the prospective payment system. Those challenges seem to be overcome now, but most health centers are seeing slower than usual funding notices of awards for their annual renewals or for their SAC renewals that come every 3 years. In addition, HRSA is only providing 6 months of awards, and so asking to redo your budget for 6 months of awards instead of a year, unless they won't change from that, I should say, until the federal budget is passed and creates a larger commitment that they can go back to the year of providing awards. Some key milestones are coming up here this month for both discretionary and mandatory funding, and we're all watching that closely to see if they're able to pass a budget and do a reconciliation to get those what would be cuts passed, or do more like a continuing resolution to extend the current funding scenario for a few more months. And it's important to note that a government shutdown appears much more likely than usual, and unlike last time this happened where the Bureau of Primary Care kept a skeleton staff on board, that appears unlikely to happen, which could then cut off payments entirely during a government shutdown. In terms of changes to the grant requirements, the executive orders won't go into all the details there, but they're in the court system right now, challenging use of federal dollars to support DEI programs, gender affirming care, and care for undocumented immigrants. And they don't affect necessarily, at least by most people's estimation, existing 330 funding awards, but it could come through new terms and conditions as part of new notice of awards. We haven't heard clients seeing changes to that, but just last week, Jim McCrae from the Bureau of Primary Healthcare said they're working through terms and conditions and executive orders, so that could certainly be the vehicle, legally binding vehicle by which these restrictions come to pass. And also the budget reconciliation could be another way that those restrictions have the force of law, even if they still are bound up in court disputes for several months. And important to note that the prohibitions are designed to attempt to curtail those focus areas, not just for federal grant funded activities, but for all the work that your health center might do as an FQHC, even if you're using other funding sources for it. Another thing that's going to go into the courts for sure, but that is the attempt that's been happening. A few tangible compliance changes there on the right side. Operational site visits were paused, but are continuing to be scheduled now. The federal representatives aren't allowed to travel, so those will be hybrid visits, but the review consultants are apparently going to come back in person. Some changes to UDS reporting around sexual orientation and gender identity, and then it looks like they've taken down Chapter 20 around board membership, and looks like they're making changes to that, which sound like are going to be terminology related changes and not otherwise affecting the core compliance requirements for health centers. So what to do about those things? Our suggestion is first and foremost to have a team-based cross-functional approach. On the internal side of things, we suggest making sure you have a small group of folks who are clearly tasked with staying abreast of all of these changes. You don't want your entire administrative team to be on webinars like this, because they could be on webinars like this every day of the week for probably the foreseeable future. So, appoint a kind of tiger team, if you will, to understand what the changes are, recommend response, and bring those things to leadership. And this, of course, could be the leadership team as well. Second, we also suggest you look at job titles, descriptions, your websites, your social media, other organizational documentation, at least to understand what might run afoul of those executive orders. Whether you make changes or not is going to be a health center by health center decision, but certainly understanding the scope of that is going to be important. As we've seen, the DOGE team seems to be targeting individual organization and contracts. They haven't, as far as I know, done that with health centers yet, but they've done it with school districts, for example. Then, review programs that might run afoul of new restrictions. So not just the terminology, but do you have programs that would be affected? Big concern is immigrant care right now, for example, and care for gender affirming care. And then lastly, contingency plans if the government does shut down. And I know Monique's going to go into a lot about those financial implications of that in a bit. And then same thing on the external side with teaming, make sure you're connecting with other health centers, community partners, and especially funders to make sure that they are understanding what the outlook might be for your health center and how you can work together to either speak up or to overcome some of those challenges that you might have with continuing all the programming that you do today. And then it's probably a tough time to call up a Chamber of Commerce and say, I want to present to you about my health center, but hopefully you have those sorts of relationships within your health center to other groups like those folks, and keeping local elected officials, of course, is appraised is really important. As a community-based organization, we each have to be out there in the community, making sure that folks know how the health centers are affected by this and how your health center is affected. On the staff, patients, and stakeholder side of things, we suggest just creating a schedule of identifying when and who you're trying to communicate with, and making that a regular structured process to make sure that especially your patients and staff know what's going on, but also the public and policymakers. Think about regularly scheduled updates so that you're not leaving folks hanging, but hey, we're going to update on a weekly basis or what have you, to make sure that folks know what to expect. There are definitely some groups affected more than others, so consider toolkits for staff or for immigrants that you care for, concerned about ICE interactions, for example, patients receiving gender affirming care. There are some great resources and training for how to work with law enforcement officials and immigration and so forth, so make sure that your staff have access to that training. There's some reference materials. We'll have a slide here to link to for those sorts of references. And then your policy to talk to the media or external agencies, make sure that staff understanding how to refer requests for comments and questions to the right folks at your health center. And then lastly, have feedback channels so that the staff who have questions know where to go, or have input they can engage with your leadership as well. On the board side of things, make sure to set expectations with the board. Some boards every board's different in terms of their expectations, but this is a time where a weekly email from the CEO might be a good idea, or something in between at least those monthly board meetings. And then strategically align with your board around compliance. So as we saw from that poll, it's I think fewer health centers than the majority who are starting to make significant changes, but we've seen a couple of stories where that's happened pretty significantly, changing policies around immigrant care and that sort of thing. You can, as an organization, choose to kind of take that wait and see approach. That's not necessarily a bad approach, but at this point in time, with this type of really pending what could be what already feels like a crisis could become more or less of a crisis, indecision or inaction, it is a strategy. So make sure that's done intentionally, and understand what your board is going to expect around vocally opposing changes or supporting certain types of changes. And then lastly, check in on your strategic plan and use this as an opportunity to rebalance and focus more on things that are going to set you up to weather this storm, especially financially. And so that's kind of the big picture, and then we'll go to any questions come up. No, I don't see any questions, so I'll hand it over to Monique to go through the financial side.
Okay, great. So based on the first poll question, it seems that most of you are in a wait and see mode to see what happens. But then some of Mike's slides did point out the very narrow margin that most health centers operate on. And so what can you do from a financial management and planning standpoint right now to prepare your health center for changes to your grant, changes to Medicaid? We'll talk about that for the next few minutes. Next slide, please. So some of the things we'll go over in this section. The Kaiser Family Foundation had a great article recently, and they put out some scenarios, and we'll go over those. Mike did discuss those in his presentation. And then what can health centers do now to manage manage your cash and your financial position? Really need to take a look at cash management, break-even analysis, some cost analysis, some PDSA cycles, and revenue cycle management. Next slide. So this is an interactive map that is included in the Kaiser Family Foundation article, Medicaid per capita cap state estimates. And if you are not necessarily familiar about where your state is as a Medicaid expansion state and trigger laws, et cetera, and estimated percent change, this map gives some really good information on it. I've highlighted, the snippet that I took is for Louisiana. And I am from Louisiana, so of course I'm monitoring the state of Louisiana closely. But also, when Mike was going over the potential budget changes, it's interesting to note the ACA expansion match rate of 57% is for Louisiana is one of the highest in the countries. And interestingly, Speaker Mike Johnson is from the state of Louisiana. So he's leading the charge on the budget that's coming from the House, the budget proposal from the House. So it is definitely an interesting situation that we are currently under, because no state has more at stake in this budget process than Louisiana, and Mike Johnson is the Speaker of the House. So it's definitely, it's going to make for good TV, I think, is one of the most recent quotes lately. So there's a link to the article here. If you go to the Kaiser Family Foundation, you can find this article, and they have some really good interactive maps in this article alone, in addition to other great references. Next slide. So what are some of the suggested financial responses that a health center can make right now? Well, of course, we all know cash is king. And, when the initial executive orders and the OMB memo came out, there was a big panic over cash because, PMS was down. Draws were temporarily suspended. And so we all know that we need to make our health centers cash position as positive as we can. So what are some ways that we can do that? The first thing is really cash forecasting. Really want to make sure that you have a good cash forecasting tool so that you know what your cash needs are over the next week, month, 60 days, 90 days, 6 months out. So if you got out of the habit of doing regular cash forecasting, now is a good time to bring that practice back and get it current. Polish up your spreadsheets, make sure that your staff is trained in how to do cash forecasting, et cetera. And you really want to consider potential loss areas now. And by potential loss areas is, as Mike mentioned earlier, some health centers are proactively making changes to their programs, to their services, in advance of guidance pushed down from HRSA based on the executive orders. Some health centers are already seeing shifts in payer mix and patient demographics. And so maybe you just now have started to see that trending, and perhaps those trends will grow. So you really need to consider those potential loss areas. So you may have, cash forecasting is, at its heart based on historical data. And historically, we had access to those service lines and patient payer mixes, et cetera. Going forward, those may change. You need to take those potential loss areas into consideration. Lines of credit. You want to contact lenders now to get paperwork current. Lots of health centers have lines of credits that some are active, some are dormant. Those that are dormant, and you've kind of had that in your back pocket, reach out to your lenders, get your paperwork current, discuss any potential increases in the lines of credit that you might be able to make now so that you get that in place while you are in a good position. If you have any active lines of credit, now's a good time to connect with your bank, make sure things are okay, and to see if you can potentially increase a line there. Discretionary spending, we always keep an eye on this, very closely looking at discretionary spending. I know some of my clients have, when the executive order and OMB memo came out, that's the very first thing that we did was there's a pause on discretionary spending. Anything that wasn't an immediate need for the clinic, directly related to ongoing operations or patient care, was just really halted. Anything that needed to be done or was, had something in the works, was being looked at by administration. Every expense. A credit card utilization. Want to really manage that, right? Without getting the staff in a panic. And, when we start talking about discretionary spending holds, et cetera, and credit card utilization, now's a good time to polish up those processes. If you've been holding off, revisiting and getting your credit card utilization current, or perhaps some of your purchasing processes have been a bit lax and complacent, maybe now's a good time to start tightening up those policies and procedures. Accounts payable management. Are you paying off your bills before the due dates? It's good to be in a good cash position and make sure we keep our vendors happy. And but occasionally we get into a cycle, maybe a rhythm of 1 week payroll, next week AP, next week payroll, next week accounts payable. And so your bills are always being paid, every 2 weeks, and you're really not maximizing the terms of your invoices. So you can push those payments out perhaps another 2 weeks or 3 weeks to get it out to your the end of payment terms to stay current, but also keeping cash in-house as long as possible. And then, of course, last resort, staff layoffs and furloughs. So, this is, again, last resorts, but now's the time to pull up your organizational chart, your staffing chart, take a look at those all of the positions, et cetera. As uncomfortable as that is, it's something that needs to be done. So we want to take a look at that. Next slide. Not seeing any questions come through. All right. Something else that we can do is a break-even analysis, and we can do a break-even analysis on service lines, individual providers, locations. So perhaps we have a service line or a department, a provider, a location that's sluggish or lagging behind expectations. Let's do a break-even analysis on those. And that's an opportunity when you do that break-even analysis to find some efficiencies. And you can look at staffing ratios of support staff to providers, administrative staff to clinical staff. Is staff working to the top of their licensure? Do you have a high level of RNs to LPNs or medical assistants? Is everyone working to the top of their license? And we look at these things when we actually put pen to paper to do a break-even analysis on our different departments or providers or locations. And so we need to consider, is now the time to make difficult decisions? Do you have a particular provider, location, service line, et cetera, that's been lagging behind expectations, and the board and leadership has been reviewing that for the last year or so, and agonizing over the decision of to keep this or to not keep it? Now's the time to do break-even analysis on those lagging lines. Next slide. Cost analysis, purchasing procedures. I mentioned that in our cash management slide. Are they too loose? Do you have too many credit cards? Are your purchasing procedures not centralized? It's easy for costs to be higher than necessary when purchasing is not centralized in an organization. It's for instance, you're ordering supplies across departments, each department ordering the supplies on their own, when and having multiple duplicate supplies, when if there was a centralized location for things as basic as Kleenex and ink pens, etc., in a centralized location. And so to be able to actually have approved vendors and purchase agreements and preferred pricing. One department may not be aware of that, and so they're ordering what they need through whoever, or et cetera. The too many credit cards is a real thing. I've seen it often. I've seen it easily get to where spending is out of leadership's view when that happens, and it does add up. Vaccines and other drug costs like COVID vaccines and perhaps LARCs. So this is one, really need to pull your clinical director in on these conversations. We did an analysis for a health center in 2024 where COVID vaccines are very expensive now. And oftentimes it is a loss leader. You can get a patient in offering COVID vaccines, but they are very expensive, and you're not going to get reimbursed to cover the cost of that visit and that vaccine. Same thing with your LARCs, long-acting contraceptives. So what this particular health center did was they looked around at their partnerships. Who did they have referral agreements with? They had public health agencies, et cetera, who offered COVID vaccines and LARCs. So you can still provide your flu, pneumonia, DTaP, and childhood vaccines in your health center, and you've met your requirement for your services, for immunizations, for your required services. And also with family planning, you meet your requirement because you are offering other various forms of family planning, but not necessarily needing to provide your LARCs. So depending on your payer mix, some of these services and drug costs can be costly and unprofitable. So again, revisit your referral relationships with community partners for those services, and make sure that you are maximizing your referral relationships so that the patients can get the care that they need and you are operating efficiently. Translation costs these days is one. Translation costs have skyrocketed over the last few years for many health centers. Have you looked at your processes for translation costs? New vendors, perhaps? Are you looking at long calls? So you have a patient that, if you look at your invoices, maybe nobody's really looking at the invoices in detail. And you have calls that are lasting 90 minutes. So you want to have someone take a look at that and see if there's a way that you could change your process to reduce the length of those calls, perhaps, or maybe get a quote from a new vendor. So there are opportunities with translation costs. So cost analysis, just to wrap that up. So looking at cost analysis, your different costs in the health center, actual to budget and year over year, et cetera, can really make a huge impact if you haven't done it recently. All right, next slide, please. Thank you, ma'am. So PDSA cycles, the good old plan, do, study, act, performance improvement processes, PDSA cycles. If you haven't done or have not been doing regularly PDSA cycles or performance improvement projects in your clinic, in your health centers, I would recommend that we dust them off. Put a dollar figure to your PDSA cycles. Not all or is easily identified, cost an amount is not as easily identified in others, but most of them can have a cost allocated to them. You want to make them, excuse me, short-term, measurable, and achievable. Some examples of a PDSA cycle that can help to impact your financial performance: upfront collections. So your front desk collections, that could be, that's a very common PDSA cycle that is short-term, it's measurable, and it's achievable, and it can help you improve processes and also improve your collections. Insurance verifications. This is a very easy PDSA cycle. can definitely impact your financial performance. Collections on dental treatment plans is one that I helped a health center with recently. Dental services can be very costly to a health center, and so do you have good processes for collections on dental treatment plans? And that's a great PDSA cycle that is short-term, measurable, and achievable. And as I mentioned in the previous slide, translation services. That's one that can be easily done in a couple of weeks. And if you're not familiar with the PDSA cycle, we certainly have some resources to help you along in that. Next slide. And then revenue cycle management. More to come with Dina and Mark for sure, but you can definitely impact your reimbursement now with some attention to your revenue cycle management. 340B assessment and optimization. There are still health centers out there who do not have in-house pharmacies, or if you have an in-house pharmacy, you don't have contract pharmacy relationships to optimize your 340B revenue, and that's always a good opportunity. 340B, while it has its challenges over the last few years, with the changes with the manufacturers, it is still a great source of revenue to a health center, and you want to make sure that you optimize your 340B revenue. Payer enrollment. I have not been to a health center that could not use a second look at their payer enrollment processes. There are ways to tighten up those processes. Not billing for services such as care management, Medicare Advantage wrap, nursing home, and SNF visits. Again, patient collections up front at the front desk. Outreach for pulling in patients for 3, 6, 9, and 12 months out. What is your fill rate for these patients? Do you have established patients, and are you properly scheduling them for follow-up visits appropriately so that you can keep your schedule as full as possible? And then AR aging. Is your AR aging over 120 days? Is that ratio larger than you would like it to be to your total accounts receivable? If so, do you need to get your billing staff focused on your current charges, 0 to 120 days, and perhaps outsource your accounts receivable over 120? It may not be getting attention. It may be that you have to write that off for timely filing, but if you are chronically in a high percentage of AR over 120 days, you really want to take a look at that. And I know that my colleagues, Dina and Mark, will be really diving a little bit deeper into revenue cycle in the upcoming slides. And so I think that might be my last slide.
Yep.
Yep, I think so. And I thought we had a poll question.
Did.
There we go. We do. So the poll question number 2, what are your organization's biggest challenges with revenue cycle management? A good way to close out my slides and kick off the slides for Dina and Mark.
Yes. That would be great if I could say, oh, I have to pick the poll. Okay, sorry. Gotcha. Okay. Organization's biggest challenges. Poll is open. And we know this is not all the possible challenges, but and you can pick multiple, but those are a few big ones. And I'm going to close the poll here in just about 5 seconds or so. Okay, closing the poll, and I'll share those results. Those were a good list of questions because they were all considered to be major challenges there. Payment delays coming on top. Okay. So over to you, Dina.
All right, thank you. I am here. I cannot see the slides.
Oh,
They left with the poll.
okay. Should be back.
Haha, there they are. Thank you very much. So some proactive steps that FQHCs can take are strengthening the revenue cycle management. One way that that can be done is to conduct regular internal and external audits. Regular audits can help identify errors early. They provide an opportunity to educate your team with up-to-date coding and billing changes, which can be really critical if patient volumes decrease. They also reduce claim denials through proactive monitoring. And also a good idea would be to conduct internal or external revenue cycle assessments. All very important. Back to the audits, they can be like a big intricate audit, like a mock CMS compliance audit or a quality assurance review, or just a basic review to make sure your providers and coders are on the right track and you're not leaving money on the table. Enhancing Medicaid verification process, also very important. This, I believe that using real-time eligibility tools are going to be vital. If you're not checking eligibility when your patient comes in and your last eligibility check was a month ago or more, we could come in and not have coverage. So we're going to want to know that. You're going to want to train your front end staff to handle coverage fluctuations. Maybe they have Medicaid on Monday and then 2 weeks they don't. And maybe we need to look at applying for a sliding fee or self-pay, or providing them with an enrollment assistance resource to maybe find other coverage. All important things. Eligibility is very, very important. We know revenue cycle starts at the front desk, and that is the biggest issue I see in the work that we do is tying up money due to no coverage, bad information. It's really going to be important that we're checking that and doing it right every time. Stay informed and advocate. Participate in advocacy through organizations like NAC, your PCAs. They're going to share your state-specific information. Important to stay up to date and create those partnerships. Attend policy webinars. Hello, stay updated. And engage in local and state policymakers. All good things and important for revenue cycle and billing. Next slide, please. So some suggested billing and revenue cycle management responses. Prepare for a change in your payer mix. As Medicaid eligibility tightens up, more individuals may lose coverage, potentially increasing the number of uninsured patients turning to FQHCs for care. We talked about that a bit. Explore opportunities to provide chronic care management services to Medicare patients. Monique touched on that a little bit. The services can create a sustainable revenue while improving patient care. It's an important service. There are a lot of people eligible, and I think there are a lot of clinics not providing the service. It just requires, a patient to have 2 or more chronic conditions that are expected to last more than 12 months, and it's consistent revenue. I would definitely be looking into that, the transitional care management, behavioral health integration, all services that Medicare will reimburse for. Expand partnerships with local organizations for patient referrals. Kind of like Monique was talking about, patient referrals can increase the number of encounters, or you can refer out for services that cost you an abundance. Anticipating fewer patient encounters means focusing on patient retention, outreach, and efficiency. Offering resources to help patients navigate coverage, like an insurance specialist internal to your organization, is going to be a really good idea. And reduction to Medicaid may result in lower patient revenue totals. We know that. It could increase in your commercially insured patients, APM programs. Maybe there's a new service line that we can provide for an alternate revenue source, like we talked about with the chronic care management. So those are my suggestions there. And Mark, you're up.
Thanks, Dina. I lost my audio a little while ago. I just want to make sure. Can you hear me?
Yeah.
Okay. So I'm going to go over a few, and these are more specific and common areas that we have found in working with our healthcare partners and doing assessments that have been common. And you know, we could spend probably 50 slides on going through various revenue cycle areas that health centers have challenges, but these are some of the common ones that we'll find that are more specific to the health center, and steer and probably focus more away from your Medicaid and look more at your commercial and your other insured patients. But other revenue cycle activity, these might include, sorry there, Mike, if you don't mind him.
Oh, yes. Yes, I'll be on the I guess.
Appreciate that. Reviewing collection rates for all of your payers, and this is really to ensure that your health center is maximizing your reimbursements. And we don't. This is something that it's not commonly looked at and not commonly reviewed with the health centers that I've worked with. But there are a couple ways that you can really look at this. One is what is your reimbursements as a percentage of your gross charges, but then if you're looking at your actual collection rate, a better review of this would be looking at the percentage of reimbursements to your gross charges less your contractual allowances, because as we all know, what you charge your insurance plans isn't necessarily what your contracted rate is. So you're really trying to get an idea of what are your reimbursements compared to what you should be receiving from your various insurance plans. Review Medicaid managed care reimbursements. Same thing here. Look at your collection rates for those. You would be surprised at how many health centers we look at that their managed care, their Medicaid managed care, they're not receiving anywhere even close to what they should be receiving as far as their PPS rate is concerned. And sometimes that is because they may have APMs or capitation that's involved in that, but you should be factoring that in when you're actually looking at those collection rates for your managed care plans for Medicaid. Make sure you're reviewing your reimbursement opportunities through other quality incentive programs as well. And I think Monique may have mentioned this. These might include value-based compensation. You've probably been hearing a lot about that recently. And this would include capitated payment options. And what I really like about the capitated payment options versus your traditional fee-for-service or your PPS rate reimbursement is really that shift away from volume-based reimbursement more to quality-based, and you're looking at more at managing at the number of lives that you're managing or the number of lives that are being attributed to you through your managed care plans. Also, a good idea for everyone, if you're not doing it consistently, is making sure that you're reviewing commercial insurance plans that are helping. That's going to help you in the long term to replace those reductions or any reductions that may happen to Medicaid, and that includes if you're losing patients to Medicaid and you're seeing that that payer mix shift away from Medicaid more to your commercial insurance. Have you reviewed those contracts we find that in a lot of cases, health centers forget about them. Commercial and Medicaid and Medicare tends to be, 80% and even higher mix, and so some of those commercial insurances are kind of forgotten about. Those agreements were made years and years ago, and when we ask, hey, when was the last time you actually reviewed the contract? We don't even know where the contract is. So it's a good time to review those. Are they still applicable? Look at what your contracted rates are, which I'll talk about in a moment. And then also, are there some insurance plans in your marketplace that you don't have agreements with that it would be worth actually making sure that you get agreements with and getting those patients into your health center. And then are your provider E&M codings comparable to national averages? And this is, Dina alluded to some chart audits and audits that you can do internally there. It's a really good idea to take a look at how your providers are coding. And on the next slide here, I'll show you. It should be some graphs, a little graphical here of your new patient codings based on Medicare and national averages. So you can see for your new patients kind of what that mix, and then that other graph there is for established patients. So there's a good mix there between your 99214s and 99213s, but we also find for new patients, the 99205s, they are often not utilized at all. Same with your 99205s for new patients, and then your 99215s for your established patients. We find there's a very, very tiny percentage that are being utilized, that are actually being coded there. And of course, a lot of cases is that our health centers are, again, heavily on the Medicaid and the Medicare side, so everything is PPS rate. They're reimbursed at an all-inclusive rate, no matter what their E&M coding is, so they kind of forget about that. But as you see this shift more towards commercial insurances, then you're going to want to really look at that and see if there is some opportunity there. And we are not recommending that you go back to your office and tell all your providers, hey, start coding everything to 99215. We're not saying that at all, of course. That's going to be based upon some of the findings that you have. But what we're suggesting is take a look at that. See if there is some opportunity within your health center that you may be undercoding, simply because your providers kind of have it in their mind that it doesn't matter what we code, because we're going to get paid. We're going to get paid exactly the same from Medicaid. I mentioned earlier reviewing your master fee schedule and update that as necessary. If you look at the next bullet there, are your Medicare rates set at least at the health center's established PPS rate? Medicare, as you all know, you have a preset PPS rate, but Medicare will pay you the lesser of what you bill them or what your established PPS rate is. And so if you have your fee schedule set so that your Medicare rate, your G code, for example, your G0467 is set lower than what your PPS rate is, Medicare is going to reimburse you based upon that G0467. So if your PPS rate is $200, but you're billing $150, they're only going to pay you that $150. Are your rates comparable to local prevailing rates? Have you taken a look at some of your other local regional health centers and what they're billing for the same services that you're providing? And are your rates comparable? Thirdly is, are your rates set to cover a reasonable amount of the costs to provide those services? And that's something that is actually all three of these bullets are something that's part of your HRSA manual, part of the compliance requirements. So that third one there is something that we find that's not commonly done. They look at it more from the perspective of local prevailing rates and just what are kind of the percentiles of where you fall and adjusting the rates accordingly. But we do strongly recommend that you look at the services that you're offering, what you're billing, and if they are covering a reasonable cost to provide that service. is the health center providing cost-effective services and treatment plans? And this might relate, a good example is probably more on the dental side of things. Have you really looked at the cost it is to provide some of the services that you're offering in dental? An example I might give was, is your health center currently offering dentures or even orthodontics, but your Medicaid PPS rate is $250? Is that really a cost-effective for your health center, or is that something that you may want to look at, and would it be more financially feasible for you to outsource or to refer those services out? And then your HRSA compliance requirement in Chapter 16, I think that relates specifically here to what I was mentioning earlier with the rate setting of your master fee schedule. Making sure that the health center is set up to bill Medicare wrap, that was mentioned a couple of times earlier. A lot of health centers, I would say 9 out of 10 actually health centers that we do assessments for, they either do not know about Medicare wrap or they think they're billing Medicare wrap, but they're actually not. Just real quick, that is basically if you have a managed care or a Medicare Advantage plan who is paying you at a fee-for-service rate and they're not paying you your PPS rate, you can bill your MAC for the difference between what your PPS rate is and what your Medicare Advantage plan is reimbursing you. And a lot of health centers aren't familiar with that. There is a setup process to get that set up, but once you do get that set up, then it's important to make sure that you start billing your MAC for those, because otherwise you're essentially leaving money on the table. I think Monique mentioned this as well. Verify that you are set up or you're billing TCM codes appropriately. These are transitional care management. These specifically relate to patients being discharged from long-term facilities, whether it be a SNF or hospitals, emergency rooms, that you can receive enhanced reimbursement through your commercial payers by billing the 99495 and 99496. A lot of health centers we find weren't even aware of this. This would again apply only to those commercial payers because those are eligible codes for Medicaid and Medicare. However, they're still only going to pay you your PPS rate, but for your commercial insurances, they typically will pay you at an enhanced rate because their RVU values are significantly higher when you compare them to, say, your 99214s and your 99215s. And then finally, as you see some of these changes, especially in your Medicaid population, some of these shifts may unfortunately be shifts to uninsured patients or patients that fall under your sliding fee. But as you look at that and as you see potentially some of these shifts, are you addressing some of those uninsured patients and how you're currently collecting to make sure that you're maximizing the collections that you're receiving from those patients? And this includes really defining within your policy the difference between patients that are unwilling to pay and those that are with the inability to pay. Because as we know, as safety net providers, you have to see all patients regardless of their inability to pay. However, you can define within your policy itself a patient's unwillingness to pay, and you can address the policy accordingly. Things there that you can address with improving your collections is what is your statement process for making sure that patients' accounts are receiving statements in a timely manner? Are they once a month? Are they weekly? Or how frequently are you doing that? Is your clearinghouse doing that? And if your clearinghouse is doing that, is that something that you are actually tracking and monitoring? Payment plans. Do you have ways to set up payment plans for your patients? And we find that sometimes these are, but a lot of times payment plans are restricted to only the billing team that's allowed to actually set those up. We encourage to expand that to not necessarily just say only your billing staff can do that, because that tends to bottleneck some of that, and some of those patients tend to lose that ability to set up those payment plans. So expand the ability for your health center to actually provide those payment plans to patients that need them. And then are there alternative ways to pay, meaning that is your health center only set up for a patient to be able to pay at the time of visit by check, or credit card, or are there other means? Can they pay online? Do they have the ability to pay even before the visit through like an automated check-in process? Do they have the ability to pay through their patient portal, and even your website itself? And then finally, collection agencies, again, we don't necessarily recommend this, but it might be something that you want to visit, because this really refers to those patients that are unwilling to pay. Again, if you have that well defined and you have those patients there, there is no restriction against you using collection agencies. The collection rate that you're going to get from them tends to be very low, but in light of the situation with the changes that are coming, we feel that every penny counts. So if you're collecting 10 cents, 20 cents on the dollar, then that could certainly help. And then finally, we did have a poll here because we did mention that revenue cycle assessments are really critical, especially now. Have you done one? So when is the last time that you actually completed a revenue cycle assessment?
And that poll should be launched. All right, just give it another couple of seconds here and I'll cut it off. Okay. Sharing that poll. Looks like the majority have done some work over the last year, which is great, but also over a third, not in the last 5 years or more. All right, well, thank you, Mark. Let's see, I'm gonna get back to, hopefully, the presentation again, and we have about 15 minutes left. I'll just probably spend about 5 minutes here on grants and fundraising to wrap up the dollars and cents kind of aspects here. So in terms of 330 grant funding, no surprise that big new federal grants are quite a bit less likely. And I have some clients just assuming that they're not even going to plan to apply to any this year, although some grants are coming out. 600 health centers have applied for new access point grants, but that is pending budgets discussions. I think the last year when we were talking about new access point grants, there was a range of $50 million to $250 million, which would mean 75 to over a couple hundred funded applications. I think probably the optimist would be thinking $50 million right now, and the realist might be thinking that they won't be funded in the short term. Like I said, there are some grants coming out with rural focus. PACE is a focus on elderly care, and then Ryan White, capacity development. So things still keep coming. Another thing though that might give you pause in terms of applying for grants, or at least change your calculus when you're thinking about whether to apply for a grant, is that estimated awards depend on the future appropriation of funds, as they always do. For those of you who have expanded hours grants or behavioral health expansion grants from last year, those were funded for a year, and that funding seems to be no reason to doubt that funding would be turned off. But in terms of it being renewed, going forward, as was expected originally, that would be a bigger risk, and especially grants that were to come out after that, just with so much focus on reducing government spending, it's hard to give those grants the same chance of continued funding going forward. So what to do about that? We talked already about investing in relationships with local and regional organizations, especially foundations. Those are really need long-term relationships and lots of investment at the highest levels in health centers, but there are some great examples of funding relationships when those relationships are in place, as well as with government agencies like counties and health departments and local hospital systems, who often give either in-kind support for health centers, or in many cases financial support, because you're oftentimes trying to see the same patients, and hospital systems would rather have those patients continue to get preventative primary care than end up in their hospital ED. Second, looking for more local and regional grant opportunities. I think lots of my clients over the last few years have been intentional about not going after smaller grants due to the cost-benefit ratio. That math might have also shifted, especially because some of those local and regional grants might not have those same restrictions that we're seeing at the federal level, so they can potentially support some of your programs that might not otherwise be able to be funded. Thirdly, increase effort to solicit donations and gifts. Most health centers have something on their website about donate here, that sort of thing, but investing in a real development type approach to donations and gifts might be appropriate at this time. Typically, health center boards aren't fundraising boards by design, but maybe there's an opportunity to add a member or two to your board who knows the development world and can start helping you to engage with large donors. And then lastly is investigate the possibility of creating a support organization like a 501c3. This is becoming fairly common in the health center world, and that your health center organization can still have a great deal of influence of that separate entity once it's created. Of course, you can help set its mission and purpose to support your patients, or perhaps your programs that are going to be challenged by federal funding, like immigrant care, DEI work, that sort of thing. I have a couple of clients actively moving forward with this now, because they really want to get something in place that will not be tied to those same strings as the executive orders as it relates to federal funding in any case. So those are our ideas there. We had some time for Q&A. We got a little over 5 minutes left, and I am not seeing any questions right now, right? Am I right? Yes, I'm not. So please feel free to type in a question. I'll maybe ask one or two of the group here, and I'll stop. Oh wait, maybe I'll actually, while folks might be thinking about questions, the slides that we'll email out will have some resources, but just wanted to note a couple here. Of course, there's our blog and LinkedIn page. NAC, of course, the relatively new organization, Advocates for Community Health, has been very active in this space. For those legal insights that we can't offer here, Feldman Lifer is one of the big trusted resources in the health center world. Of course, your state PCAs are super focused on tracking these issues. And then immigration issues, specifically the California PCA has some great resources there. And of course, Community Link Consulting, you've just heard about the financial impact or the potential financial impact. And of course, we are well versed to help in all those different areas there. And in the slides you'll see are the contact information for us, the four of us as well, and please feel free to reach out. So Q&A, I wanted to ask, we can just do kind of a round robin if you like, but from maybe this is I think maybe Monique and Mark question, I'm not sure, but if you were a CFO at a health center looking at kind of forecasting things, how would you approach, creating budget scenarios? Are you going to, create 3 different visions of the future? Are you going to break it down by impact to Medicaid, impact to Medicare, private pay? How are you going about doing that kind of forecasting? So you're not hearing you, Monique, but you're unmuted. I'll mute you and unmute you. No. Mark or Dina, any thoughts on that?
This is working.
There she is.
Oh, yeah. Oh, you're live.
So I would probably do a scenario with definitely a shift in my payer mix, anticipated shift in payer mix. The impact to Medicaid is going to be there, I would imagine, in some form or fashion. So the impact to Medicaid, beginning at maybe mid-year would be different than what your current Medicaid revenue is. So some sort of reduction in Medicare, shift in payer mix might be wise. And then again, I cannot stress enough to you how revenue cycle optimization right now is for a health center. I have yet to go into a health center where they did not have some way to improve their revenue cycle, either through training your front desk and billing staff, or having services that you're not billing for, such as the care management services that most health centers are doing 90% of the work. They're just not billing for it. And then, again, Mark and Dina gave some really, really great other examples of ways to improve it. And every health center has some hole in their revenue cycle where they're leaving money on the table. I would virtually guarantee that happens. So a deep dive into revenue cycle is critical at this point.
And I definitely agree with Monique on the budgeting of the payer mix shift there. But on the revenue cycle side too, I noticed in the poll, it looked like a large percentage, 45, maybe 50%, said that they did had a revenue cycle assessment done within the last year. Even for those of you that have had one recently done, I would probably revisit that assessment and see, are there things in that assessment, recommendations, or challenges that you had that you haven't been able to address yet, because revenue cycle is such a monster. I mean, it's a huge part of your operation that sometimes it does take time to address it, especially when you're trying to address all of it. So are there things, for those of you that have completed one in the last year, are there things that you missed or that you have not been able to get to that maybe you want to focus your attention on in these coming months?
Yeah. Thank you. And then maybe a question for Dina. So if we do see changes to Medicaid eligibility to the point where states have to start reducing their support for the same enrollment as today, what does that look like over time? Is it hit a health center all at once, or is it going to be whoever has a November start day, that's when they might lose their coverage?
I'm not sure how we're going to determine when coverage is lost or how that's going to come down. I think the most important thing I would say is work your aging, work your denials, identify your trends. If there's, one provider or one coder that needs some assistance teaching and training, because there's not going to be a lot of room for error. We're going to need to be running things tight and send out clean bills and not tie them up, because I don't know when eligibility could change.
And it's going to differ for each state.
Yeah, that's a big one.
Yeah.
But as far as billing goes, do your audits, do your risk assessments, make sure your people are doing the right things, work with your front desk, make sure that they're collecting and that they're checking eligibility, so that and you're not sitting on a claim 30 days because you're waiting for it to come back. Like, you don't have that kind of time.
Yeah. Great. Well, we are right about at time. Any closing thoughts from our crew here?
One thing I have always found is if there's one industry that is resilient and can pivot is the FQHC industry. So I'm confident that our partners here in this industry are going to come out on the other end and still maintain the quality care that they provide to their patients.
Yeah, well said. And there's just a ton of advocacy going on, and it's been a relatively stable and highly successful program. So I am also optimistic, although there's some short-term planning that would definitely be a good idea to get everybody's ship ready to sail through these seas.
Yep.
All right. Well, thanks for everybody who joined. Again, the recording will go out, and we appreciate your attendance.
Thanks,
Thank you.
everybody.
Thanks, everyone.
Bye.